All right, so I'm presenting a case of a 63-year-old female with history of heart failure. Initially, she presented with respiratory failure and found to have an EF 20%. Initially, she was treated medically, discharged on ambulatory dobutamine, and then she had a mitral clip the year after her diagnosis of HFrEF. She continued to decline, and she ended up admitting to our center for refractory heart failure complicated by shock, initially requiring femoral balloon and then axillary balloon. And then we're a heavy heart failure center, so she was discussed for advanced therapy, and she ended up having a HeartMate 3 LVAD. Despite her post-operative course was unremarkable except for mild to moderate aortic regurgitation. She did fine till the next year when she started having severe +3, +4 aortic insufficiency. She became symptomatic with dyspnea, bilateral aortic extremity swelling. And then we did a TEE, and as you can see, there is a residual, probably moderate MR, and there is this severe aortic insufficiency, wide regurgitating orifice, wide vena contracta, indicative of severe aortic insufficiency, as we can see in the short axis view as well. And we can see that there is restricted leaflet movement, especially in the non-coronary and the left cusp. So what do we do next? That's my question to the audience and the panel. What are our options here? We have a VAD patient who's having aortic insufficiency. It's quite common actually to have AI. Some reports says it could be up to 50% to have mild to moderate in the first 6 months, but it could be up to 30 to 40% for patients to have severe aortic insufficiency. And this happened partially due to a few reasons that I go quickly. First thing is change in hemodynamics. When we have the inflow cannula with continuous LV loading, that decreases your LV filling pressure, and the continuous flow from the VAD depends on the angling of the outflow cannula with the ascending aorta. That would decrease the gradient. But most importantly, the decreased intrinsic flow from the LV through the aortic valve leads to leaflet fusion, fibrosis, and restriction, and that's the main driving reason for this patient to have an aortic insufficiency. So what are our options here in terms of management for this patient?
How often do you see this in main campus, Melinda?
I'm not sure I've seen enough of these to have an opinion. I mean, this is relatively a rare situation. And Rhonda, what do you think?
Yeah, I mean, seeing this degree of AI, I think, is relatively uncommon for us. For what we see, this is if I'm reading echoes in the echo lab and LVAD patient, I see this much AI. It's really standing out to me.
What about you, Dr. Gillen?
In terms of how often we see this? Yeah. So I think we saw it more often before we recognized the importance of letting the native aortic valve open at least part of the time in people who were on LVAD support. I think the valves that remained essentially closed, no antegrade flow, and flow rates that were okay with their aortic valve not opening, those were the ones that got into trouble, I think, more predictably and earlier on. So we see it less often now that we set the VAD setting so that the valve will open. Will open.
To this, I mean, you may see a little bit, but to this degree, I don't recall seeing.
Okay. Go ahead, Ferenc.
So again, excellent discussion. So our options here could be a surgical by closing the aortic valve itself, but this carries the risk that if there is any issue with the outflow cannula, the patient will drop dead. And the other option would be doing a surgical aortic valve replacement versus percutaneous approach, which could be either a septal occluder device or a TAVR. And I know Dr. Kabadia did a retrospective analysis and meta-analysis comparing the difference between septal occluder device and TAVR back in 2017. And there was no difference in terms of AI severity. They're just same percentage of people have device migration and more paravalvular leak in the TAVR group. So again, this is the same thing. We can see how bad the AI is. So we do our thing, same thing for any TAVR. We do the CT planning, the CT abdomen pelvis, looking at if they have any access issues. We didn't have any access issues. We were above the threshold of 5 millimeter. And then we did the gated CT chest, 20 to 40% systole, looking at the annular size, and few cuts below, looking at the LVOT. Given that there is no calcium at the annulus and the leaflet, we decide to go with core evolute valve, given more stability and less risk of migration and embolization compared to Sabian. So we size this valve unusually compared to what we size other valves with the annulus. We size it based on the LVOT perimetry. So we decided to go with the 29 core evolute FX for this patient. And again, as we decided to go with the LVOT size because, as you can see here, once we go below the annulus, the LVOT funnels down, and we need to oversize for this aortic insufficiency case. And then we had a 14 French sheath. We advanced a big tail catheter. We crossed the valve. And then we had assessed the hemodynamics. And you can see here, there is LVAO uncoupling. You can see that this is not the typical aortic waveform we see. That's because of the continuous VAD flow. And this is the LV waveform. You can see this conflict. We dropped the LVAD speed from 5,300 to 3,500, and then we exchange we advance a confined wire through the big tail, and then we pull back the big tail catheter. And then we slowly advance, we exchange the sheath for the delivery system, and then we advance slowly, and we were happy with the position of the valve at the annulus.
Would anybody recommend a different valve? A different prosthesis? Maybe another self-expanding, or if you have any research valves that you are doing in main campus?
I'm not an interventional cardiologist, so the answer is no.
If you're meaning like would this patient be a candidate for the Jena valve?
Jena would make sense, yeah, here.
Yeah, so I don't know if with the, it's still a clinical trial for us, so my guess
they're opening a registry for LVAD for these type of patients with LVADs now, but we don't have it, and we don't even have the other trial.
Yeah, no, we're doing we're part of the trial, up at main campus for Jena valve, and the device has been working really well, but that's getting into the trial there are a lot of exclusion criteria.
Yeah, no, these patients definitely would not qualify, but then they have this registry. Okay, keep going, Ferraz.
So we were happy with the position of the valve here, and then we start slowly deploying the valve, and then we start doing some just buffing to make sure that we don't need to readjust and the device didn't move. And then we don't usually do TAVR under TE, but in this case we did, and then we were happy that the valve is finally engaged at the annulus, so we decided to go ahead and deploy the valve. So we start pacing, and then we deploy the valve, and we made sure that the valve is detached from the delivery system, as you can see here. And then we were happy with the results. There is no device migration, and there is no residual AI or paravalvular leak. So given that this patient is a VAD patient and we dropped the speed, we decided to go up in the speed and see what happens. So we waited around 10 minutes, and the device didn't move, maybe a little bit to the LVOT, a few millimeters, but now we're seeing a large amount of paravalvular leak at the perimetry extending from like around 4 o'clock to 12 o'clock. So now, so what do we do next? What are our options here? We deployed the valve, and probably maybe we undersized in the beginning, and we're having a paravalvular leak. What are our options here?
A sapien valve. Yeah. And what would you recommend? Jenny was doing the T, so I'm not asking her, but you are the structural imager, Rhonda. So what would you tell if Samir was in this case?
So, at this point, I think, say your question one more time. Did I miss
So what would you tell if you see that, 10 minutes later after you release the valve, you see that little AI? It's minimal AI, right?
Yeah. There's a little bit of AI, but it's it looks like it's kind of paravalvular.
Is that actionable or just leave it alone?
So, I mean, in a self-expanding valve, that might continue to expand over the next few days until it's full size, and so potentially that could get better, or you could do a little gentle balloon and try to get rid of it.
Expanding, but the leak is increasing.
Correct.
Yeah.
So, and then
So
the valve also...
and even in the long axis view, we see that the valve is shifting, so it's going more ventricular. So if we compare the image right after deployment and this image 10 minutes later, we see that the valve is shifting ventricular. So we see that, the LVAD is actually suctioning that valve. And actually, in the short axis view, even though it looks minimal, it's composing more than 30% of the circumference. So I would call this significant.
Thank you, team, for the input. So, as discussed, we decided to go with another valve. So before that, we advanced through the left radial axis GR4 guide, and then we snared one of the paddles just to minimize the risk of device migration or embolization of the second valve. And then we exchanged the sheath for a long E sheath, and we sized the Sabian valve based on... this thing is not moving.
The problem here is that there is no anchor to that valve. Keep going.
It's not letting me go.
Click.
Yeah. All right. So we slowly advance Sabian 3, 23 millimeter based on our CT sizing, and we drop the speed again. And then we were happy with the position of the valve, and then we would start pacing, and we inflated the second valve just few millimeter proximal to the core valve. And then this is our final images. We didn't see any residual paravalvular leak, maybe trace AI, but we were happy with the result. And the patient did well, symptoms improved, and she actually she was in the hospital yesterday for a driveline infection. She's doing great. And so take-home message is that this is a challenging situation, especially in the settings of continuous flow and the risk of device suction into the LV cavity and lack of calcification, so risk there's not the device anchoring to the annulus could be challenging, and we still don't have the data from the Jena valve with the anchoring arms. That the clinical trial is still running. So, thank you.
Thank you. Yes. One question here from the panel.
So, Mauricio, I'm just curious. So you decided to put a sapien in with the goal of stabilizing and expanding.
Correct.
Why not trying a balloon? You were worried that would destabilize the valve entirely and it would fall into the ventricle?
Yeah. So the thing is that we saw, after 10 minutes, we saw the valve shifting, and then you could see that, you have many configurations of LVOT, but this was a flare. And we spoke, there's a guy in Colombia that's been going crazy about doing AI with this, and they asked him, and he identified those phenotypes. And then the other thing is that why not ballooning? Because the ballooning still would not anchor the valve. You can expand it, but the problem now is not a problem of opposition, it's a problem that is shifting down, and maybe you don't have skirt to seal the annulus. So I think that the core valve is a great stent to anchor a sapien, and that's what we did.
Okay, thanks.